So, research. People's eyes glaze over when you say research. I used to be one of those people. If someone mentioned research to me, I just would go, I don't understand that, and I don't want to know about that, and that's not me, because I'm a nurse and I just do nursing things. I'm a clinical person, I don't want to be part of research. And so for some of us, it's a bit tricky when we think about research. But I'm going to talk today about our community nursing service. Now, I know a lot of you are practice nurses, but you could start a small project with just one person, because that's what I used to do. I used to just do my own projects in my own little world of HIV nursing, because I had no one else to share it with. I was the sole practitioner within our service. And or you could collaborate with other practices that are local to you and do some collaborative work. So there are ways around it, even though you think I'm just one person, how can I make any changes? And I think it's kind of timely that we're looking at this now because of International Nurses Day. So research, one definition of research is it's the creation of new knowledge and the use of existing knowledge in a new and creative way so as to generate new concepts, methodologies and understandings. So I think we all get that. But this is what we see. So we all bang on about evidence-based practice. How many times have we heard that and gone, yeah, evidence-based practice? But it does provide a foundation for decision-making and approaching clinical care, and it's the backbone of nursing. This is my colleague Kurt Anderson. So I said to him, now, when I say research to you, what do you think? And this is what he did. And then he screamed and ran out of the door. But he and I do a lot of work together. But what happens is nurses create barriers when they're thinking about nursing. So, that's a great shame because people do, when I speak to people, I can see their eyes glazing over, or I see them just kind of disengaging. I'm just, I've got to go and get something from over there, and they're gone. Or people just say to me, oh, that's just not me, I'm not doing it, that's ridiculous, I haven't got time, there's no way I'm doing it. But we have great ideas. Nurses, we're smart people. We see things that sometimes nobody else sees. Our clients or patients tell us things that no one else listens to, and we notice trends. And we're often the first people to go, hey, something weird's going on there, or I've noticed that this product's not working as well as I thought it was going to, and we're the ones that notice it. And also, we're the ones that do something about it. How many times have you worked with your peers and colleagues that have great ideas, but they never do anything about it? Whereas nurses, we do things about it. So we're very well placed in the workplace to do research. But often we don't perceive ourselves as being researchers. We're not scientific, we don't have the skills, we don't understand how to develop a project, because we may not have been taught that, or we've been taught a bit of it at university but we've never done it in practice, or we've just assisted in other clinical trials of other people. So we're not really clear about how we do it for ourselves as nurses. And more importantly, if we don't have support from our clinical leaders, then we can't do it, because you need support to have the time and the resources to engage in research. So going back to International Nurses Day, here's our founding mother, Florence Nightingale. So Florence Nightingale based a lot of her work on research. So she did statistics from the Crimea War, and she noticed how she started to collate how young men were dying in the Crimea War. And so she started doing some stats, and the next slides will show that. And she improved conditions for the soldiers, and then the government then took on some of her work and improved conditions for public health in Britain. So that was, a long time ago. So this is, I'm sorry, it's not a very good slide because I just got it off Google, of course, but it just shows you, she looked at causes of mortality in a year and she mapped it. And so she said, okay, this many people died from wounds, this people died from other causes, and this many people died from infection. And then she started working on how she could work on the infection and wound management. So, that was a long time ago, and so it's a great foundation and historical path for us. So I just briefly want to talk about my area health service. Just to give you a bit of context about why we had to change our research philosophy. So I work in Sydney Local Health District, which is a big metropolitan health district in Sydney. We care for nearly 700,000 people. Most of our people in our catchment are from other countries, and we have the highest multicultural health service in New South Wales. So we have a lot of people speaking English as their second language, and so they have a lot of different cultural context about health. And we have a significant proportion of Aboriginal and Torres Strait Islanders living within our boundaries. And it's expected, and this is going to be me, in the next 2 decades, people are going to get older. So we've got to look at how we're doing things. And all of you that are from a major city would probably recognise this. Sydney at the moment is a nightmare. It's a construction site. It doesn't matter where you go. I drive around every day, and I can drive 15 minutes before I'm stopped by either apartment complexes being made, roadworks being done, the light rail. It's an absolute nightmare. You go to visit somebody yesterday, you go today, the road's been stopped. So you have to find another way to go around. So Sydney at the moment is a nightmare, and I would think it would be very similar in other major cities in our country. We're having an expected increase in population. So the councils, we have so many councils in our catchment, they've agreed to have 75,000 new residences in the next 3 years. So that's a lot of people that we have to now think about, okay, how are we going to provide health for these people? And in the next 3 years, it'll go up by 66,000, and then in the next 10 years by another 120,000. So that's a lot of people we're expecting in our area health service. So, of course, our area health service is budget minded. We're totally over budget at the moment. It's a nightmare. They haven't been employing people for ages. But we have to look at research as an area health. And so they've done these research goals, and they want to be innovative, leading edge and internationally recognised. And a lot of our hospitals are now. We needed to collaborate with other people like universities, research groups. We need to translate healthcare into practice. And there's been studies shown that only about 17% of research actually gets translated into practice. So that's a lot of work people are doing that's going nowhere. And that's not good. It's not good for health budgets, but more importantly, it sucks the life out of you if you've done all this hard work and it fizzles out to nothing. So, and I know in where I work, we get all these fantastic brochures. They sit in a cupboard. No one hands them out. And I know a lot of work's been done on them. Printing costs, audio, visual, all this work's been done into something. It just sits there. So we need to translate better. And we need to get grants from people, because money is important, sadly. So where I work is a district nursing service and a child and family service, and these are just some of the things that we do. You'd be very familiar with that: wound management, hospice in the home, palliative care, and HIV services for us local to Sydney. We have 5 area health services, 5 community health services. So our community nurses work from those 5, and we cover certain catchments across Sydney. And so in community nursing, our research wasn't very good. So we had no projects that was service-wide. We had 1 or 2 nurses just doing little local things, and that was me doing some work around HIV. And I was lucky because I also work with HIV services, so they could support me financially and also give me access to other clients through clinics, so I was very lucky to do that. But our Director of Nurses was committed to helping us to change the culture. So we wanted to improve research knowledge and skills. We wanted to transform our attitudes, because attitude, if you can change that, you're halfway there. But we needed to provide skills and mentorship. And so we thought, what do we do? So Kurt, the man that was in that photo at the beginning, and myself were asked to go around to the 5 health centres and just do an in-service. So we just went to talk about research, and we did a pre and post test. And we talked about what type of researchers there are, clinical reasoning, what quality improvement is, and what available assistance was currently around. And we just caught them. We gave 5 dates, we went into the centres, so we got 41 people attending. And we asked people, what's something that you see that you're curious about? Because as soon as we said research, they all went, oh no, not research, oh, we don't want to come to this in-service, oh no, it's boring, oh no. So we pitched it as, okay, so tell us about things you're curious about. And so people were talking about, oh yeah, you know, I've tried this and it hasn't worked, or that hasn't been very helpful, or things like that. So it was interesting that people could talk about something they were curious about. So as you can see, 12 people of the 41 said, yeah, I've got something I'm curious about. When we asked them about research, so have you got a research idea you're interested in? The numbers dropped because people think about things in a different way, and the word research was our barrier. So we started to think about, okay, we need to change that word. So we then, after doing this, we decided, okay, we collaborated, during this research process, the education session process, what we asked them was, what's your problems with research? Time. We don't have time to do it. We're too busy. And we're all really busy in practice. Doesn't matter what practice you're working in, whether you're working on the wards, in the community, in trials. Health today, you're on the run. That's just the way it is, unfortunately. Lack of knowledge. People were terrified of doing an ethics submission, which I totally understand. No confidence, and they just had negative attitudes towards it. So we collaborated with the University of Sydney School of Nursing, and we had a little forum. So we wanted in the forum to just come up with 5 ideas. So we did that, and then we decided to disband our policy and practice group and make it a research group. And Kurt and I chaired and co-chaired it, so we were the clinical leads on that. So the Director of Nursing said, okay, I'm going to free up time every month, you've got to get together. We wanted all the clinical leads of the service, so we wanted the NUMs, the CNEs, the CNCs, and anybody that was just generally interested. And we decided it wasn't going to be a working group, it wasn't going to be a committee, this was just going to be a collaborative group where we'd come and sit, chat about some ideas and see how we go. So we all got together, we identified what education we all lacked, and we sourced education from other places. So, for example, we got the ethics people to come talk to us about how to do the ethics. We then linked in with the ethics, so we created a partnership straight away. People didn't know how to do a literature review, so we got the librarian in to show us how to do a literature review, and we linked with the library. So every time we brought someone in, we forged a link with them, and then we started to use them, and people were really willing to help us. We saw that there were people in the group that had some great experience, so we started to tap into each other as mentors for each other. We established a share drive because we're at 5 different geographical locations, so we had to do that. And we set up a register so people could put in projects, and if someone had an idea, we wanted 2 or 3 people to be part of that project. So if someone went on leave, someone got sick, the project could continue instead of getting stuck somewhere. And we did a hands up for help. So every time we have a meeting, it's just a matter of brainstorming really. People get stuck on a certain issue and we brainstorm it. So these are some of the examples of the research projects we've come up with. And they're quite varied because of our difference of experiences and interests. So it's lower leg stuff, nurses' attitude about infection control, palliative care satisfaction, improvement of HIV things, that's about keeping people safe with their HIV levels, perinatal depression. And we also did some QI projects. So for some people, they're not ready to do a full research project with ethics and all that entails, but it could be a quality improvement project. So we've got a lot of those on the fly now. We've just redone our IV policy, so they've just done a pre and post huge education attached to that. Care of catheter, because we're finding people were struggling in the home with looking after catheters. Wound assessment, I've just written an online HIV nursing module for the area because people aren't seeing, people with HIV have lived in a HIV bubble and now they're becoming chronic care, so people aren't recognising stuff. And we've got 2 fantastic Aboriginal health workers, and they've started a walking group with attached education to it. So in 2018, we still have our ongoing support from management, which is absolutely essential, and we have 25 projects. So in 2.5 years, we've gone from nothing to 25 projects. We now do a journal club every quarter because we wanted to learn about how people write stuff, how things are written in sort of research language in publications. We've had several nurses do conference presentations, which they never thought they could do. We've had a few manuscript publications in our team, and we've done lots of linking with different services, which has been fantastic, and with community organisations as well. So moving forward, we need to maintain the momentum because, sometimes when you think about research, it is a bit dry. We need to increase skills with getting grants for money because money is important. We want to get more of our nurses doing formal research qualifications because that's really important to maintain that mentorship, and we want to get better at statistical analysis. Mainly that's me because I'm pretty hopeless at it. So as a nursing service, we totally had a shift in culture. We went from being terrified of it to embracing it, and we've accepted it that this is just the way the state of art now. We just have to be mindful and smart how we do things. We've increased our curiosity as a group. We've linked ourselves with lots of other services, and now the ethics department has made an official complaint of recent times saying there are far too many nursing applications, to which we say hurrah. And personally, I've noticed in the group, our nurses have increased their knowledge and their skills. They're not afraid of ethics anymore. We all still hate it because it takes a long time to do and it's cumbersome, but we're not afraid of it, so that's good. Our nurses can all do literature reviews now easily. They can look up stuff. And we've had all different types of presentations. And, it sounds small, but to be able to present for the first time and get through it and to have your first thing published is an absolute personal thrill. So for some people that have said to me, I never thought I'd do that, they're really chuffed. So it's really great as a personal achievement. And, people aren't afraid of research anymore. They've got confidence. And now we've had people in the group that started without a clue who I see mentoring other people, which is fantastic because we want that sustainability in our service. So in summary, we need to translate our research into practice, and that's what we're really trying to do in community health. And as I said, you can do it in any of your practices with one idea. That's all it takes. One simple idea, and you can change people's lives. And we have to, because the community's evolving and they expect a lot from us now. The people today with internet access and knowledge, sometimes good, sometimes bad, they have high expectations of us as individual nurses and as services. So we have to be smarter how we do things. We've got to be responsive to the community and to the individual, but also to the health budget because that's the reality. And we've got to stay true to our history with Florence. So, she advocated for our patients, and that's what we do every day. And we can do that through research. And there's our little group meeting. And that's it. Thank you very much.